Well, again, my name is Vicki Russ, and it is an honor to present our data to what I believe is the most important part of both Oley and Aspen, and that's the consumer. This article was published in the American Journal of Infection Control, and I'm particularly proud of that because that is a journal that's read by more than what I call the choir or Aspen, but really practitioners in the field who we wanted to get the word out about the importance of HPN and the risks involved. You'll probably have heard many of your providers talk about evidence-based practice. We believe that's the best outcomes when we take into consideration those three components: the consumer preference, the resources available, and the evidence. When you think about consumer preference, it's a PICC line versus a tunneled catheter, a Hickman. The resources, if the consumer is looking at or the patient is looking for a PICC line, but there isn't the staff that can put it in, or the expertise, or the surgery schedule isn't open to put in a tunneled, those have to do with the resource components. And what I would like to talk about today is that most important piece, which is the evidence. They're all important, but that evidence, what we were seeing more and more is HPN has been around, home parenteral nutrition has been around for a long time, but there is not a large data set. And large data sets, particularly what we call registries, are helpful in trying to understand phenomenon that are going on and to describe that picture. So Aspen was acutely aware of that need for some current data in the US about HPN, and so went to great lengths to develop and create the Sustained Data Registry. This is a voluntary registry. There are some registries, data registries, that are mandatory if you're starting a new drug, or some of the Medicare stuff you have that are very specific, that if a patient is getting dialysis, there's, they have to have data and put it in. The HPN data is not like that. There's nothing in your provider requirements that says that they have to enter the data someplace, and that creates a lot of problems. So the Aspen registry, the Sustained Data Registry, was a voluntary registry in that providers could choose to participate and submit their data or not to the registry. It was prospective and observational. Many of the studies that are out there about HPN are chart-related, so a practitioner may go back into a chart and do what's called a retrospective review. We really wanted to set up the questions early on in the Sustained Data Registry and collect data that would help answer those questions about HPN therapy. And the data includes all of the voluntary sites that entered both adult and pediatric data. So what you'll see today is both adult and pediatric data combined. The purpose of this study was to describe the central line associated bloodstream infections, or CLABSIs for home parenteral nutrition, for the patients that were followed from 2011 to 2014 in the Sustained Data Registry. So in order to be included in this study, we needed both what we called the baseline data, when patients were initially enrolled into the Sustained Data Registry, and then when they had another provider encounter, whether they came in for a checkup, whether they came in with a problem, that follow-up visit. So we needed to have both of those so that we could look longitudinally at what was happening with the HPN, and particularly the catheter-related infections. I think it's important to note that 21 of the 29 sites who volunteered to collect data and submit data to the Sustained Data Registry were hospital-based outpatient providers, and the rest were like home care providers that, or smaller entities that didn't have maybe one or the other. But many of them were hospital-based. And that it's also important to note that we went back and asked the sites how they were determining which data were entered into the SUSTAIN registry. Because as a researcher, you're always concerned that perhaps your data are being cherry-picked and only the best data go into the registry. And when we went back and asked the sites, 83% of those were consecutively enrolling. So it was all comers as they were coming in. So the majority of them were not being cherry-picked or selected. There were some sites that chose only to enter brand new HPN patients that were just starting and hadn't been on it for a long time. And so that constituted a fair percentage of that other, 17%. So there were 1,046 patients in the registry for which we had data. And of those, 10.7%, or almost 11%, experienced at least one infection, one central line associated related infection during the time they were followed in the SUSTAIN data. When we look at that, the risk of having an infection is different for somebody who has a catheter and parenteral nutrition for 1 day versus someone who's been receiving it for over a year or more. So in order to standardize that, we look at a rate, and the rate is determined by the number of infections over the number of PN days. And these were PN days for which we were following them in the SUSTAIN data registry, and then times 1,000. And so what you want as both a consumer and as a practitioner is for that rate to be 0 or as close to 0 as you can get. So that was the overall rate for this group that we had. Then we wanted to try to dig down a little deeper and see if we could see differences between groups. And right off the bat, the thing that was staring us in the face was this difference between adults and kids. And those are defined as adults who are 18 and older or younger than 18. And the difference in that infection rate for those, and I'll talk a little bit more about the limitations of this study later on, but know that for the SUSTAIN data, what we found was that kids had a higher rate of infection than for adults. That the payer source, sites were asked what the payer source was for the therapies, and Medicaid, those that were receiving Medicaid had a higher rates of infection than both private insurance and even Medicare. We think sometimes that elderly persons have higher risk of being sick or not well, but if you look at this, the rates of infections for those that were 65 and older, which is where most of the Medicare patients were in, was about the same as the private. It was the Medicaid. Males were higher, and while those rates were lower, there still was a difference between males and females, and again, minorities versus whites in terms of those infection rates. From a research standpoint, we look at the statistics and we talk about chance. If we flip a coin, we have a 50% chance that it's going to be heads. And so what we want to know is, what are the odds that this could happen just by chance? And we set what we call the p-value to be 0.05 or less. So when you see the asterisks beside those, the children, the Medicaid, those differences were what we call statistically significant, that there's a very low chance that those were happening just by chance alone. We also, in addition to the demographics, wanted to look at the catheter characteristics. Surprisingly, the PICC lines actually had a little lower infection rate than the tunneled. Most of the patients that were registered in the SUSTAIN database, over 90%, were either PICCs or tunneled catheters. There was a smaller percentage that were ports, and the ports had the higher rate of infection there in this study. When we look at duration, So the duration of the HPN, whether they were on it for less than 90 days or greater than a year, it seemed that the longer patients were on HPN, the lower the rate. And that might make sense as people kind of learn to kind of what works for them and the sterile technique that's required to deal with these lines over time. So the rates were significantly different between those categories. Single and double lumens, if some patients require a single lumen, others require a double lumen, maybe for therapies. It's thought that the more manipulation is required when you have 2 lumens, you've got to take care of 2 kind of ends there, that rate goes up, and it did in this study. There were very few triple lumen catheters, but there were no infections reported in those few triple lumen catheters. So we do see some statistical significance in those as well. Ethanol locks are used for as a means to prevent infections for these CLABSIs. And surprisingly, so you see a difference, a statistically significant difference between the ethanol locks, between those who reported having an ethanol lock and those who did not. And yet it's in the opposite direction. So you would expect kind of the ethanol lock to have a lower, whether those individual patients were already had other underlying conditions, most likely that contributed to this difference in an opposite direction. That's kind of a limitation with the data registry. We don't get to go back and ask or randomize from these. But it is important to note the use of anti-infectives. So sites were asked if the patients were on antibiotic therapy. And so it was a yes or a no. And there really was no difference about in the rates for infections based on whether they were on antibiotics or not. As a researcher, anytime, there's no perfect research study, sadly. But we look at the limitations and how much we can generalize these data to a population or use these data. So when we talk about registry data, it's observational. We didn't have any control over who was in which group, so we could randomize the groups and maybe equalize the potential differences that we don't really know. So it's observational data that we have here. And we had to combine data for potentially dissimilar groups. I can't tell you how much I went round and round with our statistician about really wanting to separate the kiddos out and dig deeper into that group. But because as a researcher we set up our questions before we start, and we don't get to go back. And there are all these issues related to numbers and statistical power and how many times we can ask these questions. We left it at this. But we also believe strongly that that's an area that really needs to be looked at, is why are we seeing these differences in kiddos? Is it an underlying condition? Is it, the type of catheter? We can't really say from this study. We only know that there is a real question that needs to be addressed here. And the voluntary data set that I've talked about before. So there's no mandatory reporting. It's potential. There's probably a lot of single providers who could not, it took a fair amount of time to go through the training, to enter the data, to look at all these things. And so the providers who volunteered to do this really should be commended, because it couldn't have been done without their willingness to see this as a very important question. In conclusion, we can make some conclusions from the data, and that is that CLABSIs are and continue to be a real concern for HPN. 1 in almost 11 people experienced 1 or more infections with these lines. And the data would suggest that there are some real differences between demographics, clinical, and catheter characteristics that need further research so that we can understand the best way to address those and reduce that CLABSI rate as close or as to zero as we can get. And that really requires prospective randomized clinical trials in many of these cases to begin to compare head-to-head comparisons. It's kind of small in print, but just to share with you all of the individual providers that willingly shared their, and these data were de-identified, so there was no way at Aspen or Sustain that we could go back and say, oh, that was Mary Jones's data. It was all de-identified data that these sites were providing to us and willing to share kind of all of their laundry. Questions?
Thank you, Vicki. Let me just ask one question first. It's the introducer's prerogative. Port, one of the interesting things that would have been nice if you could have determined what the teaching was is that ports, the ones that are totally under the skin, a lot of us teach people that if they're going to use a port, they have to access it every single day and de-access it so that it's not providing a route in for the bacteria while you're not infusing. And it would be really nice to be able to determine whether there's a difference in that practice. And of course, you don't have any idea what people are being taught in this kind of questionnaire. So, and the other one thing was I was going to say with the ethanol locks, it's possible that, as in our practice, if somebody had not had infections, we didn't usually use ethanol locks because they were already doing it well. So how could we improve on perfect practice? So you may have had the high-risk people in some of the practices who use the ethanol locks, and they may already have a tendency to have more infections. So, okay, you have a question.
The question was about various different catheters. Did you check out Broviac, Hickman, or other kinds of catheters as to success rate or infection rate?
In the sustained data registry, when providers enter data, they will describe the catheter, but in order to put them all together, so that when you start breaking out catheters to very specific brands, we lose what we call power, or the ability to begin to extrapolate the data. So they were categorized as a tunneled catheter, which kind of works similar to, which is different than a PICC, which is different than a port.
I just know that there have been some people that say Broviacs last a long time, and maybe Hickman's, I don't know, everyone has different things, but I wondered what your research had said if you had actually broken it down to the different kinds of catheters as to which worked better, or which had less infection rates.
Right, we didn't ask that question for these data, and I'm not sure, given the sustained data, so cost a lot of money, a lot of time. These were all volunteers, so the sustained data registry is no longer continually collecting the data. So you only have this frame of 3 years, and I'm not sure if even your question about length of time, how long does a Broviac last longer than another catheter? I don't know if we could even ask that question.
And one thing that might happen if they had selected out Broviacs is they probably would have a preponderance of Broviacs in the children's group and not in the adults, because the Broviacs are much smaller catheters. So that could have screwed things up further. So, okay, we have one back here.
Yeah, I had a question. For patients that already had an infection once, did you do any studies about repeat infections for those patients?
So the question was, did we do more in-depth analyses for infections to see if it was a repeat infection? When patients came into the study, their baseline data, they could have been on HPN prior, to entering into the study, but day one was considered the day they entered the study, because all of the data prior to that was retrospective, and the sustain is about prospective data. When providers reported an infection, there were questions that were asked about the kind of organism, if they had previous infections, and there were some, as you can tell from the group, that had more than one infection for that rate, but there was like 11% that had one or more. So most of them had one.
Let's get the
sorry.
microphone up.
Sorry.
Oh, here, we have one more back there.
Hi. I have two questions. I was wondering whether education level had anything to do with the probability of infections. That was one. And the second one is, I'm a math teacher, so please excuse this question. I was confused that you had probability. I wasn't sure whether those were probabilities or percentages. So when you said 0.35, is that really 35%, or are you talking about less than 1%?
The rates are what's being reported. The asterisks after those tell you the probability that those rates would occur by chance. So you're actually seeing the rate, which is a measurement of the number of infections divided by the total number of PN days, parenteral nutrition days, times 1,000. So we could standardize the exposure to the risk, which is the catheter and parenteral nutrition, so that someone who's only on parenteral nutrition one day is standardized to the one who's exposed 365 days. So
Okay, so it was hard to compare those probabilities to the percentages that were
Yeah, there's no probability. The only probability is what is the probability of getting that rate, those differences in rates, by chance.
Okay.
And that's a statistical test that is done. That's what we call the p-value, or the probability that those two rates would occur by chance alone, the difference in those two rates.
Okay, and we have one more question, and that'll be it, so.
I have three, but I'll condense them. Was there any way for you to control how the catheter was cared for in the home? Was it an infusion company, a VNA, who was doing the dressing, what products they used? That's my first question. The other thing is, for the CLABSI infection, how did you define it? Was it by culture tip, by blood cultures? Because so often somebody spikes a temperature, they come in and everybody's like, get every tube out of them. And then you find out, of course, the PICC was never infected. So is there a way, and then there's some facilities that do culture tip that come out positive or negative, but that's kind of gone by the wayside. So how did you determine what was really a CLABSI?
Okay, let me go ahead and answer those two. So the first one had to do with...
How did you standardize what care was delivered in the home?
So the care,
For the
these are
catheter.
providers that are entering the data, and so it was very easy for us to get who was the payer source, the kind of catheter they had. We lost a lot of data when we started asking questions about who's caring for the catheter
Who's doing the
at
dressing
home.
change?
Yeah, and so we really couldn't address a lot of those questions that we'd really like, how much, what teaching they had, those kinds of things. And then the definition for infection, so when you look in the literature about HPN, there are a lot of small studies, and they define, you're absolutely right, that infection differently. And that makes it difficult to compare, because now we're comparing apples and oranges. In the sustained data registry, there was a very specific definition for CLABSI, which was the central line bloodstream infection. So it did not require that the catheter had to be removed to be cultured.
Good.
Yeah, so we use those standards.